Welcome to the Karate Institute course on headaches, clinical strategies, and treatment applications. So what I've done in this course is I've tried to put together like charts, diagrams, things that can really explain for you as a clinician how to differentially diagnose different types of headaches, and then most importantly, what the pathophysiology is of the headache. You really can't successfully manage someone that's got chronic headaches unless you understand the pathophysiology. So what we're going to do is we're going to go through the most common headaches. We won't cover every headache. We'll go over the most common headaches you're likely to see in clinical practice, and then we'll go over the pathophysiology, which then leads into what mechanisms are you looking for, and then what type of variables as a clinician you need to address in order to help deal with the patient's headaches. Now, headaches is one of these things where sometimes you have patients that come in and that's their chief complaint. They're like, I have chronic migraines, I need help, I don't know what to do with them, I've tried all the different medications, nothing's working for me, I want to try a functional medicine approach. And that becomes the main focus of your care with them. Other times you'll have patients that come in, they have a whole list of things, and headaches is just one of them, and you probably will end up just working on other things you think are more bigger priorities, and over time, a lot of the things you're already correcting to make them healthier just indirectly resolves your headache altogether. So those are like real clinical scenarios that things are applied to. Now, in a functional medicine approach, typically it works best for people that have chronic recurring headaches. It's not really the model for acute headaches. So when people have chronic debilitating headaches and they keep having recurring for years, and medicine, pharmacology has not worked for them, they really become a good candidate for a functional medicine approach. Now in this course, we're going to go into clinical concepts of headaches first, then we're going to go into part 2, which is focused on migraines. Then part 3 is all the other types of headaches that are not migraines. And then we'll review everything in part 4, and then also go over red flags with headaches, and then do the Q&A. Okay, so when we look at the concept, when we look at the course structure here, we're in clinical concepts of headaches. Now this is the courses at the Karate Institute that we have, and you can see here, migraines is way down here. Now, for this course, there's going to be other course materials that are going to really apply to serve as adjunctive support. So let me give you an example. Like hormone imbalances can be a key variable with someone that has chronic migraines. But in a 6-hour course, we can't go over all the principles of balancing out hormones. But we do have there's a course on that in the Karate Institute list. Another example could be, sometimes people get traumatic brain injuries and have severe headaches, and there's a significant neuroinflammatory component to it. We don't have the time to go over all the concepts and variables that involved with managing neuroinflammation, but we do have a course for that as well. So here I marked arrows of all the different courses that could help supply the information you may need when it comes to managing headaches. The focus of this headache course will really be there for you to understand the structures, how to differentially diagnose, understand the pathophysiology, but you may need to take deeper dives in certain topics related to the variable that's involved with your patient's headache. Now for this first lecture, we're going to go over clinical concepts of headaches. So let's talk about types of headaches first. Now, there are more than 200 types of headaches according to International Classification of Headache Disorders, the ICHD-3. However, about 90% of headaches are tension and migraine headaches. So if you ever get a chance to look at the International Classification of Headaches, you're going to see all these headaches. Some are just going to be almost funny when you see what's diagnosable as a headache. But when you really look at the list, there's tension and migraine headaches are the most common, and I made the list for the other things that will cover the most likely headaches you're going to see in a private practice doing functional medicine. So these are going to be the headaches we're going to focus on. The migraine and tension type headaches are going to be a huge part of our focus. We have 2 lectures just on migraines themselves, and then we're going to spend a lot of time with tension type headaches. Now, with migraines, there is a vicious cycle. And one of the things we're going to cover is we're going to review all the pathophysiology of migraine vicious cycles. And if this vicious cycle tends to get more and more amplified, like if these vicious cycles between vascular inflammation, microglial activation, and neuroinflammation, mitochondrial dysfunction get more and more amplified, this is when a person ends up developing chronic recurring migraines. And this is what we're going to talk about unpeeling in our course. We're going to go over the research, we're going to go over the mechanisms, we're going to go over clinical applications, so we can start to unpeel the vicious cycle of what migraine pathophysiology is. And in a real clinical setting, it may take you 2 years, it may take you 6 months to work through a patient. And as you look at headache management, you have to understand a key concept. Headache management isn't like you have the headache and you don't. You actually have to understand headache management is about, we're going to talk about frequency, duration, and severity. And that's your baseline. And then over time, I'm going to go, hey, are your headaches less frequent? Good. Then we're on the right track. Are your headaches less severe? Great. Or your headaches, is the duration of your headaches not as long? Great. And that's how headaches resolve. Migraines resolve in a fashion where you're dealing with frequency, duration, and severity. Sometimes, clinically, you'll get lucky and you'll address a couple of variables and they just don't have them anymore. But most times you have to go through this concept of unwinding a vicious cycle. Now with migraines, there's this vicious cycle, and then there's activators of this vicious cycle. And we'll go over the list of activators. It's more than this list here. And you really have to look at the combination of trying to find all the activators and trying to find all the things that are winding up the web to address something like migraine. So that's going to be a huge focus of this course. Now, tension type headaches are the most common type of headaches. If you've had a headache, it's most common. If you've ever had a headache, it's most likely you've had a tension type headache. Tension type headache is basically when all the muscles around your neck, shoulders, back, parts of your head just become tight and they cause pressure. That's a tension type headache, okay? And tension type headaches have their own vicious cycle. They have their own pathophysiology. And we'll go over the pathophysiology of them. But basically, it's myofascial contracture. It's that sheath around muscles start to contract. There's impingement of nerves when they do that. There's local muscle ischemia. There's a cutoff of blood supply to those muscles. There is dehydration, electrolyte imbalances, dehydration, hypoglycemia are common contributors to those things. And then once this vicious cycle starts with muscle inflammation and local ischemia and muscle contracture and myofascial contracture and it activating pain fibers within those muscle fibers, that's when you start to get these band-like tension type headaches. So we're gonna spend a lot of time going over tension type headaches. And with tension type headaches, there are various things that can cause tension type headaches, which sometimes are called its own form of headache, but they really are tension type headaches. Like a dehydration headache really is a tension type headache. Like a hypoglycemic headache when someone's blood sugar drops is really a tension type headache. Alcohol hangover headache is really a tension type headache. People have sleepiness deficiency headache, that's really a tension type headache. So a lot of times people will refer to different types of headaches by what the trigger was, whether it's stress or dehydration or lack of sleep or alcohol hangover or something. But really the mechanism itself is that it's a tension type headache. So we'll go over that in more detail. And then we'll go over all the mechanisms that drive this web. There's a series of mechanisms that drive this web. And when you have someone who's got reoccurring tension type headaches, what you want to basically do is you want to be able to find out what these variables are, what these mechanisms are, and then address those clinically. So we'll go over the thought process of working someone up if they have reoccurring chronic tension type headaches, and then what are the variables that are involved, and then trying to figure things out. Now with these tension type headaches that cause this myofascial contracture vicious cycle, it's an allostatic model where multiple variables start to add up to each other until they break a threshold, which then causes a headache. So for example, if someone just had lack of sleep, that might not be enough. But if they had repetitive muscle contractures, let's say they were, working in their backyard, they had a lot of stress, they didn't sleep that well, their blood sugar dropped, all of a sudden they had this massive tension type headache. And the combination of all those variables together tend to cause it. When a patient has reoccurring tension type headaches, that's where you want to look at all these individual variables and see what the clinical applications may be. Now let's get into other types of headaches. A next common headache are these cervical myofascial headaches. And these are, like tension type headaches, involve the tightening of the muscle sheath, the myofascia. But the key thing is they refer to the head, even though the cause are tight muscles within the neck itself. So these are the muscle referral patterns. So we'll make sure you know how to identify these myofascial trigger point headaches. These are missed all the time in healthcare. And sometimes they really need, manual therapy to break up those myofascial tight bands. There's also TMJ myofascial headaches, where sometimes people have bruxism, or they clench their teeth at night, or they may have had some trauma to their jaw, and all of a sudden the muscles get tight, and they start to get headaches all over. And it's just these muscles, the masseter muscles, the pterygoid muscles, they start to refer to different parts of the head, temporalis muscle, and these cause their own series, their own form of headaches. Then we have another form of headache called cervicogenic headaches. And cervicogenic headaches happen when people injure the ligaments and the soft tissues of their neck. This could be from like a car accident. This could be for someone who played sports and had repetitive head injuries over a period of time. They start to add up. These are the cervicogenic headaches. Another really common type of headache, that's common in all practices, will be like the sinus headache. These are pretty obvious to identify because someone has sinus pressure and they have all the symptoms of sinusitis, and then they have a headache caused by all that pressure of all the mucus congesting and putting stress on those tissues in the nasal cavities. We're also going to spend a lot of time talking about post-traumatic brain injury headaches. These are very, very common. They're overlooked. Because these brain injury headaches, these are headaches that occur years after someone had a brain injury. They don't happen like the day after, and that, always. Sometimes people with head injuries have headaches, but for the most part, someone will get a head injury and they get chronic brain inflammation, they get vascular inflammation, they start to have dysautonomia, where the sympathetic parasympathetic integration becomes compromised. And maybe 6 months later, maybe 5 years later, they start to have some headaches, and with time they get worse. And the key thing with these brain injury type headaches is they're usually triggered by activity of the area of the brain that's injured. So if the frontal lobe is injured, then things like executive functions, focus, concentration, types of tasks tend to turn on their headaches. If they damage the back of the brain, like the cerebellum, then things where they're in a car going around wavy curves where the cerebellum has to integrate what's happening with visual spatial information coming to the brain. Or if they're in an unsteady area, they may have a headache that turns on because their cerebellum is injured. So I'll give you a list of all the different regions of the brain that can be injured, and what are the triggers for those, and how you can identify traumatic brain injury type headaches in your practice as we get into the course. Another form of headache, or thyroid-based headaches. And thyroid hormones play a big role in modulating some of the mechanisms of vascular dynamics. So thyroid hormones modulate serotonin metabolism, they modulate smooth muscles, they modulate vasomotor tone, they modulate prostacyclin production, which coordinates prostaglandins, thyroxines in blood vessels. All these things have an impact on the tone of blood vessels. So when people have hypothyroidism, they may have 3 different types of headaches that occur. They could have migraines turn on for them as a key variable. They can have tension type headaches become more prevalent with other variables, or they may develop what's called hypothyroid associated headache. And this is like a consistent headache. It's non-pulsatile. It's typically bilateral. It's not triggered by light or sound. Nausea and vomit isn't common. Those are all things that are common with like migraines. But there's just this chronic headache that's just there and no one can figure out why. And these are sometimes hard to diagnose because the patient may not have any actual thyroid symptoms or clinical presentations. You just have to run a TSH at times and see if it's there. And the key factor of this diagnosis is once they start thyroid replacement, they start to have their headache slowly resolve. But it can take 2 to 6 weeks. So it's not something as like the first time they take levothyroxine, their headaches are gone forever. There is some time for the feedback loops in the body to adjust to those and the vascular dynamics to adjust, and then they're able to resolve their headaches. Now, another type of headache you need to be aware of in clinical practice are hypertensive headaches. And the technical pattern, someone has very high blood pressure, typically in the 180 systolic, 120 diastolic range. They get this pressure, this throbbing, pulsating pressure in their head. And they don't always have to be this high, but the classification criteria used for standard diagnosis requires it to be very high, like hypertensive crisis. But many people will experience hypertensive type headaches from stress with the exact same pattern, back of the head, front of their head. And there's a direct relationship to as their blood pressure comes down, their headache starts to resolve. Okay, so we'll talk about those. And then there's menstrual-based headaches. And menstrual-based headaches typically occur right when estrogen levels drop, usually at the end of the cycle, the beginning of the cycle. That's where many times people develop their migraines flare up, their tension type headaches flare up. So we're going to get into those headaches. You can also have expressions of menstrual cycle headaches as a woman starts to go into perimenopause. As you look at the age categories, once a woman starts hitting 40 and going into the next few decades, they become very susceptible to migraines. And part of this has been shown because of these fluctuating drops of estrogens, which is really the same mechanism of these menstrual migraines. So when estrogen levels drop, they cause a significant change in vasomotor tone, and that can lead to all different types of headaches, migraines being one of the most common. And then another headache, which gets a lot of attention when you read about headaches, is cluster headaches. And cluster headaches are pretty rare. Cluster headaches occur in about 0.1% of the population, but they're so devastating and so unique that you'll often hear about them. And this is basically an ipsilateral type of headache where they have like tearing, swelling of their eyes. It's an autonomic phenomena. And many people who have cluster headaches explain it as the worst pain they've ever felt in their life. And they're called cluster headaches because they have these episodes of pain that come and go, and they're pretty significant. And those are, associated with these patterns. And some people even think about suicide when they get cluster headaches. Some people will injure themselves with cluster headaches. They're very serious. And by the way, there's not many options in functional medicine for them, and only hope with them is just pharmacology gives some relief. But the good news is they're about 0.1% of the population, so this is on the bottom of the list, but you should know about them. And then the last one on this list we're going to cover is what's called medication overuse headaches. This typically occurs with patients that have migraines, and as they take their various types of migraine medications, mostly which are drugs that block one of the different types of serotonin receptors to slow down the inflammatory trigger that's taking place with migraine. Over time, patients will tend to use those drugs more and more. And then there's a side effect from using those drugs, which is the dull, chronic, constant headache that takes place. And you should be aware of those, especially with some of your patients that have migraines and are taking migraine medication. They may actually develop medication overuse headaches over time and then have two different mechanisms for their headaches. Now, if you look at this list here, this list should cover approximately 95% of the headaches that you will encounter in your clinical practice. So this is what we're going to focus on. The goal for the rest of the course is to make sure you know how to differentiate diagnose each type of headache, and then know what the pathophysiology is, know what the web is, and then know what variables you have to look for as a clinician, and then how to address those things in practice. Now, let's go into another important concept, which is the spectrum of headache severities. So when you look at the scale of headache severities, here you can see on the left-hand side, no headache. And then on the extreme side, headache secondary cranial pathology, like a tumor, vascular compression, brain infection, cerebral aneurysm, hemorrhage, something very, very serious, right? And obviously, headache secondary cranial pathology, when patients have these, they're going to get many times, you're going to see neurological deficit signs with them. They're going to explain the worst headache they ever had in their life. I mean, there's going to be some red flags that we'll go over that's used. They're helpful to identify them. Now, for the rest of the headaches, we start here with, least severe to more severe. There are these tension type headaches. These tension type headaches occur when people's blood sugar levels drop, they get dehydration, they abuse alcohol, they have electrolyte imbalances, they get myofascial pattern tightnesses from overworking a muscle, overdoing it, and they get this tightness around their neck and shoulders, muscles around their head, and that causes that band-like pain. Those are all tension type headaches, okay? Not very severe. It can be very frustrating. They don't impact a person's quality of life where they can't do anything. They can still function and do things. They're just miserable doing it the whole time, and they just, feel awful. So then you have sinus headaches. Sinus headaches, can vary. Some sinus headaches could be severe where a person just can't function and do anything that day when they have them. And other times it's just mild pressure, but they're not very severe as far as mechanisms that could be underlying with those types of headaches. Then we get into headaches due to physiological imbalances. And this would be, so for example, a hypertensive headache or a hypothyroid headache or a menstrual headache or medication overuse headaches. These are headaches that are occurring because there's some significant physiological imbalance that needs to be addressed. So those are pretty important to identify. Now we start to get into some serious types of headaches, and starting with migraine. So episodic migraine means you have an episode once a year, 3 times a year, twice a year. It's not that big of a deal versus chronic migraine. Now, if you notice your chronic migraine is very severe, And part of the reason is because you have white matter brain injury damage with migraines. So we have it listed, in episodic here because it's just an occasional issue, but it becomes chronic, much more severe. And then cluster headaches. Cluster headaches are similar to migraine headaches. There's some potential theories that there's also some white matter injury when people have these cluster headaches from these autonomic shifts that take place that then create an inflammatory cascade that starts to injure neurological tissue. And then the next one here is post-traumatic brain injury headache. And these are overlooked many times in clinical practice. They become like the weird patient that has like headaches if they smell things that are different, or if they have, exposure to various stimuli. It could be like a carpet on the floor immediately gives them a migraine because they have some visual spatial problems or things like that. Anything that's sensory based to area of the brain that's injured can cause those types of headache. Those are big deals for us because when people have post TBI headaches, they actually don't know that they have this chronic inflammatory, encephalopathy. And so basically a post-traumatic encephalopathy. And these types of injuries clearly have shown to lead into Alzheimer's and dementia and Parkinson's disease, and they need to be addressed as soon as possible. Okay. Now, migraine here, as we go along here. So we get into migraine here with these white matter brain injuries. So you can see when you look at what's happening with a chronic migraine patient, there's actual pathophysiology, which we'll go over in great detail, but there's ischemia and inflammation that damages the white matter. And there's actually, lesions that are clearly identified in MRI. So the characteristic pattern of white matter lesions in MRI. Many people go in for a regular scan and they go, oh, you must have migraines. Like, how'd you know? You have an MRI. And what the MRI is basically showing are these hyperintensities, these white hyperintensities you see with the arrows. These are injured neurons. They're damaged. This is brain injury. So, migraine isn't just headache. Migraine is actually brain injury. So when people have migraines, you really want to make sure they resolve it as soon as they can. So, even pharmacology becomes really critical for them to stop that inflammatory cascade so they don't damage your brain. It's not something you play around with from a preventive medicine point of view and, let them just suffer because they don't want, you really want to address that with whatever is appropriate, especially pharmacology that actually works for them. Like there isn't going to be an herb that blocks a acute migraine attack. There's not going to be a supplement that does that. We'll go over the research on these things, but they're very serious. So you see we have them on our list over here. Okay. Then as we move from migraine, we get into headache secondary to cranial pathology, and we'll go over how to identify red flags for that as well. Okay. Now let's move on from types of headaches and spectrum of headache severities to headache diagnosis. So ultimately, as a clinician, what you're trying to do is you're trying to go through your medical history, ask questions, look at their headache characteristics, and then come up with some kind of diagnosis. Now, a really important concept is there are no lab tests or imaging studies to diagnose headaches, right? Now, you can see white matter lesions with migraine, but there's lots of white matter lesions that can occur with other types of inflammatory conditions of the brain. So it's not specific for it. And most people that have migraines in the early stages will never have any findings on an MRI. So migraines and headache and all types of headaches are basically based on your ability to identify characteristics from their history and then come up with a diagnosis, okay? Now, the essential questions that you want to ask during your history is where is the headache pain located, right? So you're going to keep asking these questions. You're trying to narrow down the list. What is the characteristic that fits for the presentation they have for a headache diagnosis? So where is the headache pain located? Describe your headache pain. So it's throbbing, it's band-like, it's compressive. Those are going to be important things to find out. How much do your headaches impact your daily function? So things like migraines will basically take someone out of function. They won't be able to do anything, right? And other headaches will still be annoying. So you want to find out how severe the headaches are. How long does your headache last? That's another important question. Some headaches, like some people with migraines have migraines for 48 hours. Some people have migraines, they only have it for 6 hours, right? Is there anything that can trigger your headaches? This would be very, very important because this can help you identify what variables to look into more as a clinician. So, for example, they would say, yeah, sometimes when I eat certain foods, I get a headache. And then you find out they have celiac disease, they have gluten sensitivity. And that was one of the reasons why they have headaches, right? Or they might say, the days where I do swimming, I get real bad headaches. And then you find out, well, they're doing repetitive muscle contractions. They're getting myofascial trigger points all over their neck and shoulders, but they're really dehydrated. They're drinking water throughout the day. All they're doing is drinking like sodas and caffeine beverages and very little water. And then they go do an excessive workout and they have these headaches and they don't know what's happening. So you want to try to find out what's triggering their headaches and go work backwards. So then you can find out the mechanisms and put it into your web, then come up with a clinical application. Number 6, are there any symptoms associated with your headaches? Or do they have any other things? Like, for example, they have light sensitivity, sound sensitivity. There's their face get numb before the headache, like an aura, like a sensory aura or something like that. Number 7, anything interesting you found with your headache? It's just an open-ended question for you to get any clues of anything else that may forget to tell you. But these are like the 7 most important questions to ask when you're evaluating a patient with headaches. Now, not only are you trying to use this information to identify what type of headache a patient may have, but you want to get a very good baseline whenever you work with a patient for how frequently they have them, how severe they are, and what is the duration of an episode. How long does an episode last? Because that's going to be your baseline to then determine care. Like that's what you have to do. And as a clinician, you're going to have to explain that to the patient. You're going to go, listen, what are we going to label as your frequency? This is going to be your baseline. And how often do you have them? I'm going to say, okay, every week. Great. Just once? Yeah, just 1 or 2 times. Okay. And then how severe are they? Then the list functions they can't do, you write that down, and then you go, how long do they last? And they might say like 20 minutes to a couple hours. Great. That's our baseline. Does that look right to you? That's what we're going to compare your future responses to. And then you write that down in your notes, and then you kind of see if they're getting better. If your only question to them is, did you have any headaches? And they go, yeah. Oh. Like you're not going to realize you might be on the right track to helping your patient because their frequency and their severity and duration may be going down. Okay. Now, as you look at as a clinician, when you hear these questions, what you're then going to need to do is understand these headache characteristics for the main headaches I just showed you. And I have a chart that simplifies all this for you, which we'll go into in the next couple slides here. So you're going to need to know where headaches are located, where do they present, where they express the pressure, the type of pain the patient expresses when they have a headache, the length of the headache, the trigger, and any special features. And once you have an understanding and knowledge of this, which I've made charts for you for each one of these things, and you ask these questions, you should very clearly come up to a headache diagnosis. Okay? So let's get into that step by step and show you where this information is. Okay? So as you go through location, type of pain, severity, length, trigger, and special features, this is something you have to know as a clinician. Like you got to walk into the room knowing these different diff dyes. Okay? And these different diff dyes I put together for you in a chart. Starting with location, let's go over location first. Now, with location, you're always going to see images like this in different medical textbooks or different articles about headaches, and they're somewhat useful, but they're not reliable at all. Okay, the only key thing is like sinus headache, you'll have pain right over the sinus area. Migraines will usually be one side. Cluster headaches will be just like over one eye. But like an exertion headache, it's not over the face. It could be all over the body. It could be all over the head. Like TMJ, it could be over the eye. It doesn't have to be over the temporal muscles here. Stress headache could be anywhere in the head. Hypertensive headache could be in the front of the head. It could be band-like. So location isn't always, these diagrams aren't always the best, but you should have a general idea of them. Now, I made a chart for you, and basically these charts you have to just know if you're wanting to really make sure you optimize your diagnosis skills for headaches, okay? And we have them for each of these different variables. So for location, the key things you need to know are migraines. The main feature is that's unilateral. It's one side. It's very rare migraines are bilateral, okay? Tension type headaches, it's just that bilateral throughout the head type of pattern. Cervical myofascial headaches, there could be some cervical muscle tightness that the patient may or may not know about, but it's referral pain to the head. TMJ myofascial headaches, it's a referred pain. It's the muscles in TMJ have trigger points in myofascial contracture of them, but they may not notice a lot of pain there. They may notice their jaw is tight, but the headaches, in different parts of their head facial region. Sinus headaches, those are very clear right around the sinuses. Post-traumatic brain injury headaches, it could be anywhere. So that's not very useful for you. So, depending on which vascular branch is impacted by a brain injury, the headache should be really anywhere. Okay. Hypothyroid headaches, it's usually both sides of the head. Hypertensive headaches, usually the back or top of the head. Menstrual headaches, typically either cause migraines or tension type headaches, which we talked about earlier. And then cluster headaches is like one side around the eye, and medication or overuse headaches are throughout the head. Now, just looking at location headaches, you're going to have a really hard time diagnosing a headache. That's why you have to look at more than one variable. But once you start to see, for example, it's unilateral, you're going to be leaning more towards migraine. Once you see it's like around the muscles, like band-like around their head, you're going to be leaning more like tension type headaches, right? So this is the key thing with location. Now, the type of pain is going to be really important for you as you go through and try to distinguish different types of headaches. So migraines are basically known for causing like throbbing or pounding feeling throughout the head. That's like an ipsilateral, one-sided, throbbing, pounding feeling is one of the key features. But it's that vascular, throbbing, pounding feeling. Now you'll see hypertensive headaches, when blood pressure is very high, they can cause that throbbing type of pattern, and hypothyroid patterns can also cause this throbbing sensation as well. So that's pretty characteristic of that, throbbing type of pain description. Tension type headaches is basically just that pressure around the head, all around the muscles, the shoulders and neck and, facial region areas. That's where most people have experienced a headache. And that's like that tight band of tension that's around the head. And then we get into these trigger point headaches. So if someone has cervical myofascial headaches where they have tight muscles in their neck that have this myofascial contracture, causing a myofascial pain syndrome and refers to the head, or the TMJ referring to the head, they're going to have this dull ache that's just there. And the key feature with them is when you squeeze the muscle that's involved, it triggers the pain more, right? We'll talk about key features in a second here. So these can be very non-specific, but also many times they just feel like a sharp pain. Many times when these myofascial patterns, these bands around the muscle get really, really tight, they cause very sharp pain that almost feels like the stabbing type of pain. So you should be aware of that. Their pain pattern is very aggressive at times. Sinus headache is very straightforward when you look at sinus headaches here. You can see that there's pressure and fullness that's involved. Now, post-traumatic brain injuries, this is going to be another key thing is they can turn on migrainous headaches, tension type headaches, myofascial headaches, cluster-like headaches, pulsatile headaches, throbbing type headaches. Anytime you have dysautonomia where the brain is not able to coordinate sympathetic and parasympathetic activity very well, you can have all types of clinical presentations. And as far as headaches go, you can have all types of pain with post-traumatic brain injury headaches. Now, hypothyroid headache will be sometimes just dull pulsing, or sometimes it's very clear, like a throbbing sensation. And menstrual headaches can really just basically turn on the migraine pattern, which is that throbbing, pounding feeling, or it can turn on that tension type headache. And then cluster headaches are that intense, sharp, stabbing pain that people want to bang their own head against the wall, very, very severe. And they have the little cluster episodes that last from 15 minutes to 3 hours, where they get an episode of severe, severe pain, then it goes away, and then they get another one, then they get another one for a day or two, and then that's gone. Those are the cluster headaches. And then a dull, constant headache that's hard to explain can be like a medication overuse headache, and also hypothyroid headache can also have that dull, constant headache. So you just have to know this chart. Okay, now severity of headache. This is also really important to know, okay? When you look at severities of headache, they're basically classified as how much they impact activities of daily living, like waking up, working out, preparing food, working, all the general things you do during the day. So migraines basically cause inability to conduct activities of daily living. Okay. Now, a lot of people confuse a very painful tension type headache as a migraine, right? Because they just think if it's really, really bad, it must be a migraine. But a migraine is so severe that a person cannot function that day. Excuse me. Now, tension type headaches, they just feel awful. Like tension type headaches, myofascial headaches, TMJ headaches, cervicogenic headaches, they just don't allow normal activities to take place. I mean, they allow for you person to do all their daily activities. It's just they're just miserable while they're doing all those things, right? And then sinus headaches can be as debilitating, where a person can function at all, or it could be mild discomfort, but they're pretty easy to diagnose because it's just right over the sinuses. And then post-traumatic headaches, depending on the type of brain injury involved and the autonomic effects, could be mild, or it's just a very subtle headache, to debilitating, where they can't get out of bed for days. Hypothyroid headache, it's mild, but these can trigger migraine headaches or tension type headaches. And then hypertensive headaches, for some people, like, they're debilitating. As soon as they try to stand up and do anything, their headache is so bad and throbbing, they have to sit down. Or it could just be this mild throbbing sensation throughout the day. And then menstrual type headaches basically trigger migraines or tension headaches and have those types of severities. And clusters being one of the most severe types of pain, and then medication review. So if someone comes up to you and says, yeah, I have a headache and I can't function at all that day, it's probably a migraine, or it's probably a post-traumatic brain injury headache, or it's probably a cluster headache, right? That's a clinician. You go, okay, well, what else is involved with it? Then they tell you it's ipsilateral. Well, if it's ipsilateral, now you're thinking cluster headache and migraine headache. It could still be post-traumatic headache. And then as you go through each of these variables, you might get a bigger clue of what could be happening. And sometimes you may not be able to differentiate between one or two things, but looking at severity as one of the variables as you go through the process is really important for you to identify the type of headache. Okay. Next question asked is, how long does the headache last? This is probably the least reliable one. Length of headache is not useful in distinguishing one type of headache from another, but provides a baseline that can be used to determine if treatment strategies can reduce the length of the headache episodes. So, for example, migraine, one of the criteria for diagnosis, it has to be more than 4 hours. Things like cluster headaches, there's little clusters of headaches that come and go, but they can have 3-hour periods, 15-minute periods. Tension type headaches could be 5 minutes. They could be 3 days. Myofascial type headaches could be there all the time and at different degrees for many, many days, or can only be there for like 15 minutes. So length is not one of the most useful criteria to help you figure out how to distinguish a headache. Now you're looking at triggers. This is another important one you always want to establish when you're doing a workup. So I made you a list of all the different triggers for each of these different types of headaches. Yep. So when you're looking at this, people that have migraines, one of the key features of migraines we'll get into the pathophysiology in a second here, is they get depolarization throughout their brain. They get something called cortical spreading. Well, neurons are close to threshold. So as the neurons are close to the threshold, they become very sensitive to any kind of stimuli. And any kind of stimuli can then trigger their headache. Okay? So it could be flashes of light, it could be loud noises, it could be strong smells, it could be weather changes, it could be hot or cold temperature changes, it could just be dehydration. They can become very reactive to foods all of a sudden that they have not been before, right as their headache is starting to develop, their migraines start to develop. Lack of sleep, stress, exertion, excess caffeine, hypoglycemia. And with people that have migraines, it's typically the same thing over and over again. So there'll be some people that have migraines that are extremely sensitive to flashing lights. That could be one of the triggers for them. And for some people, it's not an issue. For other people, it could be really strong smells. Like someone could walk into an elevator with a really strong perfume scent, and then that can trigger a migraine for someone. And for other people, scents are not an issue. But you're going to have to kind of find out the characteristics of what your patient's migraines and triggers are. Anytime you hear someone telling you like trivial things like smell or light or sound cause a headache, and then you find out it's unilateral, and then it's the most severe and they can't function that day, there you go. Now you go, okay, this is migraine. It becomes pretty straightforward, okay? Now, tension type headaches, these are going to be caused by like stress, lack of sleep, dehydration, blood sugar levels dropping, like physical exertion, too much alcohol, too much caffeine, and then electrolyte balances. And even those people that have like food triggers, like gluten, dairy being really common inflammatory foods for people, those types of inflammatory triggers tend to promote these tension type headaches. We'll go over the pathophysiology more. But remember, you can't just look at the trigger itself. You have to look at other variables that are involved. So for example, Lack of sleep can promote a tension type headache, but it can be one of the variables that also promotes like a migraine type headache. So as you look at the other variables that involve with the presentation of the headache, you can then start to distinguish them. Okay. Now, when people develop cervical myofascial headaches, where they get painful in their head, usually from like some kind of muscle strain, like you can have someone who's like swimming all the time and they're in the pool when the muscles are moving their head back and forth. And over a period of time, the myofascia, the sheath around the muscle, gets really, really tight. And then they start to get headaches. So they might tell you, I get headaches every time after I swim. Or they could be working at a workstation where they're always turning their head to the left as they do things. They say, when I go to work, I have headaches. When I'm at home, I don't have headaches. You go, well, what's the thing at work? And then you find out, well, what's your workstation about? And you find out they're just constantly rotating their head one way. And then you like put your finger in their muscles and push on it and their headache comes back. That's a cervical myofascial headache, right? So that'll help you distinguish that. Clenching teeth is a major one. A lot of times people don't know that they have bruxism. They just clench their teeth at night, especially under times of stress, and they get headaches. But other times patients will know that they're, waking up with a really, really sore jaw, and that's when they have these headaches that occur. Or they could have like had trauma to their jaw. They could have their jaw open and they went to the amusement park and went on a roller coaster, and as their jaw was open, as they're moving back and forth, the jaw moved around and they strain all the muscles in their jaw, right? Or they were biting into something and like they hit a seed and the muscles weren't ready for that, and now they have this contracted muscle that's there. And now just when they get a little bit of stress when they sleep, they clench their teeth and now they wake up with a different type of headache. So any kind of jaw movement, biting, causing headaches, you pretty much know it's like more of a TMJ issue. The cervicogenic headaches are a little bit less clear than the myofascial ones. Cervicogenic headache is someone injures the ligaments and tissues of their neck, and it may happen like some kind of car accident. They had a whiplash injury. They've injured some of those ligaments and things in the back of their neck. They could have been playing sports, played soccer. They hit the ball with their head. They did it over time, and they kind of like a repetitive trauma to those ligaments, and over time they've injured them. And now, as they've gotten older, and other things start to happen, like the tissues aren't regenerating as fast because of age or other inflammatory mechanisms, they really start to have headaches all the time. And with cervicogenic headaches, they're really triggered by head movements. And anytime they have to keep their head straight they have to keep their head, head supported instead of like lying down or putting the head back on a headrest, they can have their headache turned on. As a matter of fact, one of the key diagnostic things is they feel better as soon as they get a headache if they lie down. They feel better as soon as the headache if they, hold their neck. Those are key features of cervicogenic headache. Okay. Sinus headaches, the trigger is going to be whatever they're activating their sinuses. Whether it's, reoccurring viral infections from a weak immune system, whether they have sinus polyps. There's even autoimmunity mechanisms of sinuses we'll get into, allergens, but those should be pretty straightforward. With sinus headaches, you're going to have to do a whole sinus workup. We'll talk about some of that a little bit later. Now, with post-traumatic injury headaches, this is going to be really important. These are going to be the type of headaches that people talk about all the time that are weird, right? They're going to say, it's so weird when my patient sees the color purple, but only purple, they get a headache. If you have certain injuries in your occipital lobe, the wavelength of purple hits those fibers, and that could be where the area was injured, and that's why they have a headache. So, like anything that's weird, you almost always think of post-traumatic brain injury, and then you try to think about where in the brain those functions may evolve, okay? For certain people, like whenever they hear like left repetitive music like rap for more than 20 minutes, they get a headache, or they get a migraine, but not other types of music. Well, the left auditory cortex is going to have activation there. So if they injured that, maybe they had a fall, injured that area in their brain, when they get that stimulus over and over again, and those neurons are injured, and there isn't enough mitochondria function there to maintain their ATP loads to handle that constant trigger, then their brain fails. When their brain fails, one of the phenomena are dysautonomia. So you can have those dysautonomia patterns that take place with post-traumatic brain injuries. So whenever you hear something that sounds weird to you, always go back and go, have you had a past traumatic brain injury? Did you ever hit your head? What kind of sports did you play throughout your life? Tell me about any car accidents you had. Any of those things are going to be really, really important. Now, if they've lost consciousness, that's a big deal because that's a huge clinical red flag. They have what are called prime glial cells. The injury is significant enough that they've lost consciousness, and depending on where their injury was, and if that area is activated, it can really be a problem. So post-traumatic headaches are really important. Now, the other key thing about post-traumatic headaches you have to know is not only is it a neurological stimulus, but one of the features of post-traumatic brain injuries is that the microglia, the immune cells of the brain, are overactive once they have an injury. And anything that triggers inflammation that activates these microglia can also impact their expression of dysautonomia and then trigger a headache. So if someone has, let's say, they injured, let's say, their frontal lobe, that they hit their head really hard and lost consciousness, they injured the frontal lobe. Now, anything that involves like neurological stimuli, like its executive functions for that area of the brain could fatigue their brain because those neurons are injured and then cause this headache pattern. But you could have someone, for example, who's, let's say, sensitive to milk proteins, and they get exposed to milk that creates a significant inflammation for them, and all of a sudden they get their headache and their frontal lobe function goes down. Now, a key feature of post-traumatic brain injury headaches is not only will they have the headache, but they will have lost some function in the area of their brain where they were injured. Right? So for executive function, they can't do executive functions anymore. For cerebellum, all of a sudden they have a headache, but their balance is off. So those are the things you want to look for with triggers for post-traumatic brain injuries. Hypothyroid headaches are another one you should be aware of. But with hypothyroid headaches, sometimes you see the clinical presentation of hypothyroidism, but many times you don't. There are many people that have silent hypothyroidism where they have no clinical presentations of hypothyroidism. They're not the classical hair loss, cold hands, cold feet, weight gain, any of those key features. They just have this dull headache that's there all the time. So the key thing is whenever you see that is just to run a TSH. If the TSH is high and they go on replacement, you should see that headache resolve. And then once the headache resolves after replacement, that's when you finally can confirm that it was actually, or most likely, hypothyroid headache that they were suffering from. Okay, people don't get hypothyroid headaches usually if their thyroid hormone dose isn't exactly right. They get them when they're the full-blown deficient. All of a sudden, they need thyroid hormones. Right? It's not like they get them when their hormones are not adjusted exactly to what their body needs. It's typically full-blown hypothyroidism, significant hormone deficiency. Okay. And then triggers for hypertensive headache is anything that raises their blood pressure. It could be physical activity, it could be stress, it could be, some kind of stimulant they take, whatever it may be. And then triggers for menstrual headaches are just going to be that drop of estrogen levels. Now that can happen right at that could happen at right at mid-cycle, where their estrogen levels drop. So like in the middle, like day 15. But most commonly it happens as their estrogen levels drop at the end of the cycle, and like somewhere between days, the last like 2 or 3 days of their cycle, the first 2 or 3 days of cycle, that'll be the common time for a trigger. Now, a lot of patients may not make that correlation between their menstrual cycles and their headaches. You're going to have to ask them. If they tell you they have a migraine every month, then you want to ask them if there's a link to a certain time of the month, each month, to your cycle. And if they say yes, then you're most likely dealing with some type of menstrual headache. Okay, and then the cluster headaches, no one really completely understands the mechanism of them. But just like migraines, bright lights, physical exertion, high altitude, any kind of just stress to the body that activates the autonomic nervous system tends to be a potential trigger for people that have cluster headaches. And sometimes they get the same exposure, have no problems. Other times this is a trigger. And again, multivariable pathophysiology. And then obviously medication overuse, headaches, they're happening with people from being on things like triptans and opioids and different types of non-opioid analgesics to deal with pain issues or deal with migraines and headaches. We'll go over that in much more detail, but there's a history of medication use that you can identify as a trigger. So these are all really important. But the key diagnostic feature to tell what a headache is are these special features. If there's only one chart you memorize and one chart you just know back and forth, this should be this one. The special features of headaches, okay? So here you will see, like for migraine, You have sensitivity to light, sound, smells, nausea, and vomiting, or potential auras. Auras happen about 20% of people with migraines, which is like they get some neurological sensory loss, like usually a visual field, or they can't feel part of their face, or something like that. We'll go over those in detail later. But the key thing is they're sensitive to light and sound, and they have nausea. If you hear sensitive to light and sound and nausea, and especially if you hear that they have some kind of aura, some symptom that lasts for a few minutes before their headache, that's pretty much migraine. The other special feature for these other headaches, getting into tension type headaches, is tension type headaches. The headache often can be relieved by massaging the neck, shoulders, or temples. So they have headache, they just put some pressure on their muscles, and it makes them feel a little bit better. It doesn't make the headache go away, but it makes them feel a little bit better. That's never going to happen with a migraine. That's never going to happen with a cluster headache. That's a big clue that it's a myofascial involvement. So usually when pressure relieves or causes more pain, you're dealing with a myofascial mechanism. The sheath around the muscle is constricting, right? So cervical myofascial headaches, the way to diagnose these very clearly is like you see pain referral that's going to their head or face. You have a history of something that may have caused tight muscles, maybe the sports they play, athletics they're involved with. Maybe they tell you that they slept weird one night in the pillow and their head was all over the place. Now they have headaches. But the key thing is if you squeeze the muscle that's involved, let's say the SCM muscle or something, or there's deep extensor muscles, if that triggers their headache pain, that's diagnostic. Putting pressure directly in the involved muscle triggers the headache. It's like, oh, it's making it worse. Perfect. Now, if that pressure is then held as the patient breathes through it for a minute, 2 minutes, 3 minutes, or a couple rounds of doing that, then eventually the headache can be resolved. Okay? But, you have to remember, if you have a patient that's like a myofascial headache, whether it's cervical or TMJ myofascial headaches, if you apply pressure into the muscle and it causes the headache, you have to finish the treatment. You have to relieve that muscle. They're going to have headaches the rest of the day, and it's going to be terrible. We're going to teach them, just keep putting pressure in that muscle until the headache pressure goes away, right? You can teach them how to treat their own muscle. The special feature of cervicogenic headaches is just that prolonged movements of the head, prolonged activities that require support of the head cause headaches. That's cervicogenic headache. That's clearly what it is. So as you go through, as you know these mechanisms, these headaches, these mechanisms, as you go through history, you can be very, very efficient finding what they have. Sinus headaches, very clear. They're going to have some kind of sinus infection. Post-traumatic injury headache, they're going to have some kind of accompanied some other type of neurological deficit, like they have dizziness, they have balance issues, they have tinnitus, they have something else that's also coming along with their headache. And some sensory-based trigger could be a factor, or something very inflammatory was a factor, but there's some neurological loss of function, even though it could be slight. Like they just can't focus and think and concentrate. They just can't do math, or they can't distinguish between different sounds in a crowded room anymore. These are all clinical clues, but I have a lot of charts to go into great detail about those. We'll go over it later. And then the special feature of hypothyroid headaches is that hypothyroidism and thyroid replacement fixed it. Hypertensive headache, the key feature is that it's just directly related to hypertension. As their blood pressure goes down, their headache is to go away. The key feature of menstrual headaches is just related to like the same time of the month that they have their menstrual cycles. The key feature of cluster headaches is like the worst pain they've ever had, severe pain around the eye with tearing. And the key feature of medication overuse headache is that they take medications and now they're having a new form of headache. And the medications are typically, headache medication or pain medication. We'll go over the list a little bit later. But you definitely want to know these special features. So as you go through your protocol, as you go through your, the steps in a clinical setting, you got to be able to history. Now, like all the time, like here's the thing with headaches. Every practitioner, oh, I know headaches. Really? Okay. But they don't, because they don't follow the steps. Like you got to follow the steps. You have to go through your diagnosis list. You got to find out the location. What a lot of practitioners do is go, I just do my thing. Just take this. This is anti-inflammatory. Or this is, take feverfew. It's good for headaches. And they just kind of read something like that. That kind of stuff is terrible clinical practice. You have to know the different types of headaches, and then the location, type of pain, length of headache, triggers, special features, to then come up with a diagnosis. Because once you come up with the diagnosis, then you can actually play the game. Then you can actually go through and figure out how to unwind it, what the causes are, and then manage that in that setting. Okay? So another key concept you have to be aware of as we get into headaches is you got to know when it's serious. When you got to know it's a red flag, you got to know like, well, should I go see someone to get an MRI or a CT scan? And these are going to be something that involves what's called the Snoop mnemonic, and the Snoop mnemonic is S, two S's, and two O's, and one P. So the two S's stand for systemic symptoms or stomach disease. So, they have like diabetes, they have kidney disease, they have malignancy. Now they have a brand new headache. You're worried about metastasis or some kind of infection that's happening into the brain or something. Those are systemic diseases. N for neurological symptoms is they have a headache and now they also have a foot drop. They have a headache and they have slurred speech. These are things that are telling you that something's more serious than just the headache, right? They may have had a stroke or something like that. Onset is sudden. Thunderclap headache is like typically defined as the worst headache of a person's life. They tell you they've never had a headache like this. It's the worst I've ever had in my life. And then another red flag is just being over age 40. Anytime someone is age over 40, you got to make sure they don't have this Snoop pattern. And then previous headache history, and if they can tell you if they had a headache like this before or not. If they've never had a headache like this before, it's also a major red flag. Okay, but we'll go over this in much more detail. But so as a clinician, as you can start to diagnose what they have and make sure it's not a red flag, then you're able to play the clinical management game. Now, as we get into clinical management with headaches, there's basically acute management for headaches and long-term management for headaches. Okay, now acute management for headaches, immediate goal is to stop the headache. Over-the-counter medication or prescription medication typically used and effective. And physical medicine therapies can be effective for some types of headaches. So functional medicine approaches such as diet, lifestyle, and nutritional approaches have limited impact during acute headaches. Like the course information I'm telling you is not going to do much for you for acute headaches. When someone actually has an acute headache, that's not really where functional medicine comes in. Functional medicine comes in for long-term management, chronic care, reoccurring headaches. That's where you really have to figure out what the mechanisms are. Now, for people that have acute headaches, the typical things like pain relievers like acetaminophen, NSAIDs, even prescribed medications like triptans, ergotamines for people that have migraines, antihistamines, whether they're natural or like quercetin or over-the-counter. Manual medicine like trigger point therapy, massage, acupuncture, spinal manipulation, lifestyle strategies like hot shower, water hydration, caffeine, cold compressive therapy. Nutraceuticals, not very effective in acute headaches. They're just not. Like the conventional approach for tension-type headaches, take acetaminophen, drink some coffee, and take a hot shower. That will help most people in the acute phase of tension-type headaches. But if they have tension-type headaches like 4 days of the week, then you got to figure out what's going on. That's where functional medicine shines. So functional medicine will be something that will be really important for long-term management. Now, long-term management of a headache, meaning you're trying to deal with the chronicity of a headache. The ideal goal is to identify underlying factors to completely resolve the headache if possible. But your initial goal as the clinician should be look at the frequency, write it down, agree with the patient how often the frequency is, write down the severity of the episodes, numerically figure out what activities they're not able to do, and then get an idea of what the duration is. That will always be your baseline. That's what you want to work with as a clinician as you work with your patients. And then functional medicine is really, really effective for these types of, long-term issues associated with headaches. So the key thing for this section so far is we're covering the headaches that are the most common you're going to see in practice. And you can see they're not that difficult to differential diagnose. You have to know the special variables of each headache, like pain type, location, special feature, the severity of it. If you know those charts and you can ask those basic questions, you should be able to easily diagnose all the different headaches. Once you diagnose different types of headaches, that's against the treatment. So this is really the focus. You should have these 7 questions always asked when you're doing a medical history for headaches. And you should know about these headache characteristics, which we've put together for you in these charts. So the diagnosis part of the headache is not going to be difficult, right? That's not going to be the hard part. The hard part is going to be like, okay, now we know it's tension-type headaches. So why do they happen all the time? Now we know this person has reoccurring or chronic migraines, how do we untangle this pattern, right? That's what we're going to focus on the rest of the time with. So not really much more to say about diagnosis. We'll highlight them as we go through some of the different headaches just in the very beginning, just to familiarize with you with them. But we really want to get into treatment applications and how to work through unwinding these patterns for the patient that has chronic reoccurring patterns. Okay, thank you.